Hello friends, let us now discuss one of the end topics of the ear, that is diseases of inner ear. Okay, let us first start with the congenital disorders of inner ear and we discuss the number one, Michel's aplasia. Okay, so what do we mean by Michel's aplasia? Now Michel's aplasia means complete absence of cochlea. So as you can see in the photograph, in the first CT scan, you can see that some part of the vestibular labyrinth is present, but the cochlea anteriorly is absent. Okay, look in the other side, you can see over here that's a spiral cochlea present on the other side, but on this side the cochlea is absent. Okay, in the second photograph, in the second CT scan over here, you can see that there is no inner ear at all. The whole inner ear is absent. You can just see the ossicles and the ice cream cone appearance of ossicles. So that is the middle ear where the ossicles are present, but there is no cochlea, there is no inner ear. So this is known as Michel's aplasia. Now remember an MCQ question, because there is no cochlea, you cannot even insert a cochlear implant. So this is an absolute contraindication for cochlear implant. Okay, this is an absolute contraindication. All right, so how do I remember Michel's aplasia? I remember Michel's aplasia by the word Michel. So who is Michel? Michelle is a famous personality. We all know Michelle Obama. She's wife of Barack Obama, and Barack Obama is ex-president of United States of America. He was president for 2 terms, and during those 2 terms, he was the most powerful man in the world. So you see, everyone listened to him, except one person. And who was that person? That person was his wife, Michelle. She never listened to him. She did what she liked. Okay, so even if you are the most powerful man, your wife may not listen to you, just like Michelle. So remember, Michelle never listens. Okay, so she has Michel's aplasia. There is no cochlea. You cannot even do a cochlear implant. Okay, so that's how I remember Michel's aplasia. Let's go to the next one, that is Sheep's dysplasia. Now, Sheep's dysplasia, this is the most common congenital anomaly of inner ear. Most common congenital anomaly. What happens in Michel's dysplasia? In Michel's dysplasia, we have a cochleosacral dysplasia. That means the main epithelium, the sensory epithelium of the inner ear is absent, and the cochlea and the saccule, they are fused together to form a common cavity. So that is known as cochleosacral dysplasia. Since majority of the epithelium is absent, therefore this is once again an absolute contraindication for cochlear implant. Okay, so next anomaly that we have to discuss is Mondini's dysplasia. Now Mondini's dysplasia, this is the most common congenital anomaly of cochlea. Okay, remember, cochlea is the auditory part of inner ear. Okay, and we discussed that the most common congenital anomaly of inner ear is Sheep's dysplasia. Okay, so remember, that's the most common congenital anomaly of inner ear. When I say the Mondini's dysplasia, this is the most common congenital anomaly of cochlea, only the auditory part. So don't get confused in it. Now, what happens in Mondini's dysplasia? In Mondini's dysplasia, the second and the third turn of cochlea, they are fused together. Okay, so as a result, the cochlea has only 1.5 turns. Remember, a normal cochlea has 2.75 turns, but over here we have only 1.5 turns with a cystic apex. Okay, now the next question is, can we do a cochlear implant in this patient? Now, ideally speaking, you would not like to put a cochlear implant in a Mondini's dysplasia. Why would you not like? Because you see only 1.5 tons of cochlea are present, that means only 50-60% of the sensory epithelium is present. Okay, and therefore your response will be only 50 to 60%. You may not like to use a cochlear implant in this site. However, let's look at this CT scan. There is a Monni's dysplasia in this child on both the sides. Therefore, you are left with no choice but to insert a cochlear implant on any one of the side. Okay, so remember, Monni's dysplasia is a relative contraindication for cochlear implant. That means you may not like to insert a cochlear implant, but if you have to, then you may. Okay, so it is a relative contraindication. It is not an absolute contraindication. Now, lastly, we have Alexander dysplasia. Okay, this is another rare anomaly, and in Alexander dysplasia, opposite to Monni's dysplasia, the basal turn of cochlea is absent. So again, this is a absolute contraindication for cochlear implant. Okay, so over here I would like to emphasize that nowadays we do not divide the cochlear anomalies into these ways. We rather divide them into hypoplasias, dysplasias, and aplasia. Okay, and we decide on case-to-case basis whether we should or should not put a cochlear implant in the patient. Okay, so that is decided on case-to-case basis, how much epithelium is present, how much response will present, and what is the status of the opposite side ear. All that is taken into consideration before inserting a cochlear implant. Alright, let us now go to the next disease of the inner ear, that is Meniere's disease. Okay, now what happens in Meniere's disease? Before we discuss that, let us briefly revise the anatomy of the inner ear, the cochlea. So remember, we have discussed this diagram of the inner ear. We know that the inner ear, the cochlea, is divided into three parts: the scala vestibuli, the scala media, also known as cochlear duct, and the scala tympani, by two membranes: regional membrane, also known as vestibular membrane, and the basilar membrane. On the basilar membrane, we have the sensory organ, that is known as organ of Corti. Now, the scala vestibuli and the scala tympani, they both consist of a fluid that is known as perilymph, whereas scala media consists of a fluid that is known as endolymph. This endolymph is secreted by a special membrane known as stria vascularis. This stria vascularis has a sodium-potassium ATPase pump. Okay, so we have discussed that in detail in the anatomy of inner ear as well as the physiology of inner ear. Now remember, the endolymph is high in potassium and low in sodium, just like intracellular fluid, whereas perilymph is high in sodium. Okay, so this endolymph is produced by stria vascularis. It is also produced by dark cells of macula in the vestibular labyrinth. Now, how is this endolymph absorbed? This endolymph that is produced in the stria vascularis over here is absorbed by the endolymphatic sac. Okay, so remember, I have discussed that there is a structure that is known as ductus reunions. Now, this ductus reunions, it takes the endolymph from the scala media to the utricle ensaccule, and from there arises the endolymphatic duct, which takes the endolymph to the endolymphatic sac, where it gets absorbed. Okay, so this is also known as longitudinal flow of the endolymph. That means it is produced in stria vascularis as well as macula, and from there it travels along the endolymphatic duct into the sac where it is finally absorbed. This endolymphatic sac is present behind the mastoid, and we have also discussed the landmark for the endolymphatic sac, that is known as Donaldson's line. Right? I hope you remember that. Now, let us discuss about the disease that is known as Meniere's disease. Now, what happens in Meniere's disease? In Meniere's disease, the endolymph production increases, or the endolymph absorption decreases, or sometimes the duct is blocked. Now, because of this, there is an imbalance between the production and the absorption of endolymph, and therefore, this endolymph starts accumulating. So, as you can see over here, this endolymph accumulates and it puts pressure on the vestibular membrane, also known as Reisner's membrane. Okay, this condition is therefore known as endolymphatic hydrops. Now, what happens to this Reisner's membrane? After some time, because of continuous pressure, the Reisner's membrane bursts. So, what happens to this Reisner's membrane? Now, because of continuous pressure, after some time, this Reisner's membrane or the vestibular membrane, it bursts, and all the endolymph, it comes out into the perilymph. Remember, endolymph has a high potassium content, and that irritates the sensory epithelium, and patient has a severe attack of vertigo. Okay, the patient has a severe attack of vertigo. Now, anything else? The ion gradient is gone. Remember, outside sodium was high, inside potassium was high, and this ion gradient led to a sound perception. And because the ion gradient is lost, patient also has sensory neural hearing loss. Okay, anything else? These patients may also complain of tinnitus. Alright, so remember, Meniere's disease is a triad of three things: vertigo, sensorineural hearing loss, and tinnitus. Some patient may also complain of oral fullness, a feeling of fullness in the ear. Okay, so these are the main complaints of the patient of Meniere's disease. Now, what happens to this patient after the burst? Now, after the burst, the Reisner membrane, it come back to its original position because the pressure goes away, and thereafter the endolymph, the potassium is reabsorbed, and this condition is re-established. Okay, so the vertigo goes away, the hearing comes back to normal, but the tinnitus may remain. Okay, so let's look at this pathophysiology in this video. Okay, so we know that the Meniere's disease is a disease of the inner ear, the cochlea. Okay, and the inner ear has two different type of fluids. We have a perilymph and endolymph. Perilymph is in the space between the bony labyrinth and membranous labyrinth, whereas inside the membranous labyrinth we have the potassium-rich endolymph. Let's look at the cross section of cochlea. You can see the basilar membrane, you can see the vestibular membrane or Reisner's membrane, and you can see that scala vestibuli and scala tympani are filled with perilymph, whereas scala media is filled with endolymph. Now, endolymph production increases or absorption decreases. So what do you see? You see a condition which we have described as endolymphatic hydrops. The Reisner's membrane bursts, the endolymph starts coming out and mixes with the perilymph, that causes severe vertigo, and there is along with that sensorineural hearing loss and tinnitus. After some time, the pressure is gone, and therefore the Reisner's membrane heals, and thereafter the potassium is reabsorbed back into the endolymph, and thereafter the vertigo disappears, the hearing comes back to normal. Okay, so this Meniere's disease presents as a unilateral disease. It is more commonly seen in males, although some book says that the male to female ratio is 1:1. Okay, So it is, some studies have mentioned more common in males, and some have mentioned it to be unequal in frequency in males and females. It is seen in the age group of 35 to 40 years. And this Meniere's disease consists of a triad of three things. Number one, episodic vertigo. So remember, vertigo comes in episodes. This disease is an episodic disease, and each vertigo episode lasts for more than equal to 20 minutes. So this is a criteria for diagnosis of Meniere's disease, that the vertigo should last for more than equal to 20 minutes. Anything else? Patient has a fluctuating sensorineural hearing loss. So there is a sensorineural hearing loss that improves in between the attacks of Meniere's disease. Patient also complains of tinnitus. Remember, tinnitus is one symptom that remains even between two episodes of Meniere's disease. Okay, so this is present even between the episodes of Meniere's disease. And as I told you, some patients may also complain of oral fullness. Okay, so the Meniere's disease is a characteristic of these three symptoms. Now, other than this, patient may also have a phenomena that is known as Tullius phenomena. Now, what is this Tullius phenomena? The loud noise, it precipitates vertigo. Okay, now why does this Tullius phenomena happens? It is proposed to happen because the bulge of the Reisner's membrane causes an adhesion of the Reisner's membrane with the footplate of the stapes on the medial aspect. Okay, the medial aspect of the stapes footplate is now adhered to the Reisner's membrane. So therefore, a loud sound that rapidly moves the stapes footplate can cause an attack of vertigo. This is known as Tullius phenomenon. So therefore, these patients are very sensitive to loud noises. Patient may also have a crisis known as Tumarkin crisis. Now, the Tumarkin crisis consists of sudden fall attacks. This is because of a bulging utricle, and remember the utricle, it maintains your horizontal acceleration, and because of the bulging utricle, the stimulus to the otolithic membrane is gone. Okay, so because that stimulus is gone in a bulging utricle, patient is not able to maintain balance and he suddenly falls. Now this is considered to be a severe stage of Meniere's disease. Patient suddenly falls, and I remember it like patient will get up and he will say, "Tu maar kin." In Hindi, "Tune mujhe maar ke giraya." So "tu maar kin." Okay, so this is sudden fall attacks experienced in Meniere's disease. Patient can also have a Lermois syndrome. Now, generally, when the Meniere's disease attack happens, patient has vertigo, and the vertigo comes along with sensorineural hearing loss. In Lermois syndrome, this is a variant of the Meniere's disease. The vertigo follows sensorineural hearing loss. So that means sensorineural hearing loss comes before vertigo, and in fact, vertigo relieves this sensorineural hearing loss. So that means hearing improves after an attack of Meniere's disease. Now, the hypothesis behind this is the sudden spasm of the labyrinthine artery. So you can see the labyrinthine artery over here that supplies the inner ear, and this is a branch of anterior inferior cerebellar artery. Okay, so you can see this anterior inferior cerebellar artery over here, and the labyrinthine artery is a branch of anterior inferior cerebellar artery. So there is a sudden spasm followed by sudden dilatation, and that is hypothesized to cause Lermois syndrome. So very easy to remember, L for Lermois and L for labyrinthine artery. Okay, and the vertigo relieves sensorineural hearing loss in this syndrome. Now we also have Henibert sign. Remember, we have discussed Henibert sign earlier also. Now this is seen in congenital syphilis as well as Meniere's disease. So what is seen in Henibert sign? This is a false positive fistula test. So that means if you press the tragus or on signalization, you will change the pressure in the EAC, patient has vertigo and nystagmus. So there is no fistula, and yet the fistula test or the fistula sign is positive. That's known as Henneberg sign, and it is seen in case of Meniere's disease. Okay, now how do we confirm the Meniere's disease? So patient has presented with these symptoms to us. So what we do when the patient has presented these symptoms to us? Number thing we have to do is we have to do a pure tone audiometry. We have to do a PTA. Why do we need to do a PTA? We need to do a pure tone audiometry or a PTA examination to confirm that this is a case of sensory neural hearing loss. Okay, because patient will only complain of hearing loss. We have to confirm it is sensory hearing loss. Now, once we have confirmed that this patient has sensory neural hearing loss, now we can give this patient IV glycerol. The IV glycerol is given in the dose of 1.5 ml per kilogram body weight. Over here, I would like to mention you can also give oral glycerol. But glycerol has a very, very sweetening taste. So much sweetening that a lot of glycerol as required in this test can cause nausea and vomiting to the patient. So we generally do not prefer oral glycerol when we prefer IV glycerol. Okay, now glycerol is a dehydrating agent. It is a hygroscopic agent. It absorbs the water. So it will absorb the water from the body as well as from the inner ear. The pressure goes down, the regional membranes start coming to normal position and start sealing. So we wait for 30 minutes IV now after an IV dose, and after 30 minutes we repeat pure tone audiometry. Okay, now if in the repeat pure tone audiometry, if in this repeat pure tone audiometry, the hearing improves, there is an improvement in hearing by more than equal to 10 decibel, then we consider it as a case of Meniere's disease. So that is our first investigation, that is the glycerol test. Okay, so in this glycerol test, we see an increase of 10 decibel in sensory hearing loss after waiting for 30 minutes. Alternatively, we can also do a speech audiometry where we will see a 10% increase in the SDS score, the speech discrimination score, after giving a glycerol dose. Okay, now before we go, let us look at the pure tone audiometry graph in Meniere's disease. Now in Meniere's disease patient, in early Meniere's disease, we will see that there is more hearing loss in the low frequencies. Okay, and therefore this curve is known as rising curve. Whereas in a late Meniere's disease, you will see that there is more hearing loss in the higher frequencies. So this is known as sloping curve. Okay, remember I just taught you Meniere's disease is a unilateral disease. So this patient will have a unilateral sloping curve. Sometimes question is asked, where do we see a bilateral sloping curve? So the answer for that is presbyacusis. Presbyacusis means old age, or you can say age-related hearing loss. Okay, and in these patients, they have bilateral sloping curve. So as you can see in this curve, both the sides, there is loss in high frequencies. So patient has bilateral sloping curve. Such a presbyacusis curve or a bilateral sloping curve we can also see in case of ototoxicity. Okay, so sometimes it is also seen in ototoxicity. Alright, now let's come back to Meniere's disease, and remember Meniere's disease is a disease of the cochlea. Okay, so patient has cochlear deafness and therefore recruitment is positive. Okay, these patients are sensitive to high intensity. Remember, I have already taught you in the ABLB lettergram alternate binaural loudness balance test. Okay, ABLB stands for alternate binaural loudness balance test. ABLB lettergram that we have already discussed in the audiometric test, and the Meniere's disease patient will have a converging lettergram. We can also do another test that is known as CC test, and the CC index, that is short increment sensitivity index, will be positive. That means it will be more than 70% in case of Meniere's disease. Again, because of the phenomenon of recruitment, as it is a cochlear disease. Okay, we can confirm the Meniere's disease with the help of an investigation that's known as electrocochleography. So what we do in electrocochleography, we compare the submitting potential in the inner ear with the eighth nerve action potential. And we know that in a normal person, the submitting potential is less than 30% of action potential, or you can say that the SP to AP ratio is less than 0.3. However, in case of Meniere's disease, the submitting potential is more than 45% of AP. So if it is more than 45, it is considered as indicative of Meniere's disease. Or you can say that the SP to AP ratio is more than 0.45. Okay, this investigation is electrocochleography. It has been used as a confirmatory investigation for Meniere's disease. Remember, there is one problem with electrocochleography, and that is it is a invasive investigation. As you can see over here, the electrode has to be inserted through a tympanic membrane. So you have to create a perforation in the tympanic membrane so as to place your electrode on the cochlea. Which part of cochlea? On the round window. So electrode has to be placed on the round window to measure the electrical potentials in the cochlea. Okay, so therefore it is a invasive investigation. All right, let's come to the treatment of Meniere's disease. Now, the treatment of Meniere's disease can be divided into two parts. The first is treatment of acute episode and acute attack of Meniere's disease. And what do we do in this? Now, we know whenever patient has an acute attack, after some time, this patient will automatically improve. Why? The pressure goes away and the region of membrane come back to its normal position, it heals. Okay, and therefore attack will go away on its own. So what will you give for the treatment? The treatment is mainly symptomatic, and that is by labyrinthine sedatives. Okay, such as prochlorperazine or cinnarizine. We can give these drugs so as to put the labyrinth, the vestibular labyrinth especially, to sleep, so that by the time it wakes up, the patient is relieved of vertigo and the hearing improves. Okay, now the second part of the treatment is maintenance phase. What do we mean by maintenance phase? It is between the attacks of Meniere's disease. So it is between two episodes of Meniere's disease. And why do we give treatment in this? We give treatment to prevent the next attack of Meniere's disease. Okay, now the maintenance phase can once again be divided into two parts. The first is the medical management, and the medical management consists of different kind of drugs such as diuretics, beta blockers, histaminics, etc. Okay, so we can give one or more of these drugs to relieve the patient of Meniere's disease. Suppose we give diuretics. So what is the function of diuretics? They take away extra water from the body. So the endolymph production decreases. Okay, we generally prefer potassium sparing diuretics in this case. We can also give beta blockers. Now the beta blockers, they increase the absorption of endolymph by opening the absorption channels. Okay, so they will increase the absorption. Now the histaminics such as beta histidine, they improve the blood circulation inside the inner ear. Therefore, they lead to an increased absorption once again. Okay, so the absorption of endolymph is increased by the histaminics. Now over here, I would like to point out one thing. We are using histaminics in Meniere's disease We are also using antihistaminics such as cinnarizine, as I discussed in the management of acute phase, as a labyrinthine sedative. Okay, so both histaminics and antihistaminics, they have their role in the treatment of Meniere's disease. We use both the kinds of medicines. Okay, let's come to the next part, that is the surgical management. Now, the surgical management of Meniere's disease can once again be divided into two types. The first is the conservative surgery, and the second is the radical surgery. The conservative surgery consists of different kind of surgeries such as endolymphatic sac decompression or vestibular neurectomy. Okay, so what is endolymphatic sac decompression? We know that the endolymphatic sac is not absorbing the endolymph. Okay, so what we can do is we can drill open the endolymphatic sac. As you can see in this short video, we can drill open the endolymphatic sac and then we can place a shunt in it. This shunt can be connected to subarachnoid space and it will slowly drain away the endolymph. Okay, so the endolymph goes away, and it is a conservative surgery because you are not damaging the hearing of the patient. We can do another surgery such as vestibular neurectomy, so we can selectively cut the vestibular nerve, the part which is concerned with balance. Okay, so this is once again a conservative surgery as you are not damaging the hearing of the patient. Okay, now if conservative surgery fails, then we have to go for radical surgery. And the radical surgery example is surgical labyrinthectomy. So what is done in surgical labyrinthectomy? The whole of the labyrinth, the inner ear, is drilled out. Okay, so the whole inner ear goes away. So we have a saying in Hindi, na rahega baans, na bajegi bansuri. Okay, in English you can translate it, there is no bamboo stick, so there will be no flute. And then there will be no noise. You will not be disturbed with the noise of the flute. Okay, so surgical labyrinthectomy, there is no inner ear, there is no vertigo. Point to remember, surgical labyrinthectomy is generally done in chronic Meniere's disease patient who already have a lot of sensorineural hearing loss. They have sensorineural hearing loss in severe or profound category. Okay, and therefore this ear is not serviceable for hearing and the patient is having vertigo. Okay, so let us understand the scenario. A patient is a patient of Meniere's disease, and this Meniere's disease is chronic. That means patient is suffering it from many years, and patient has severe or profound sensorineural hearing loss in 1 ear, unilateral. Okay, and because of this, patient does not have any benefit of hearing from this ear. So patient has no serviceable hearing from this ear. Okay, any other problem with the patient? Patient has vertigo, and this vertigo is causing problems. He is not able to lead a good healthy life, and therefore we can go and do a surgical labyrinthectomy. Now this question has been asked in the AIIMS exam. The question is gold standard treatment for intractable vertigo. So intractable vertigo means you have tried all the conservative methods and they have failed. Okay, that's the word intractable. Intractable vertigo in a patient of Meniere's disease. The answer is surgical labyrinthectomy. Okay, this question has been asked in the AIIMS exam recently. So please remember the question. The gold standard treatment for intractable vertigo, the answer is surgical labyrinthectomy. Gold standard means complete stoppage of vertigo. Okay, nowadays, before going from medical to surgical, we have something in between that is known as intratympanic gentamicin therapy. So what is done in this? We know that the gentamicin is a ototoxic drug. Which type? It is a selective vestibulotoxic drug. So this gentamicin is injected in the middle ear, intratympanic. From the middle ear through the round window, it goes into the inner ear. Okay, so it is absorbed in the inner ear, and there it kills the vestibular labyrinth that is causing vertigo. Okay, so there is a selective killing of the vestibular part of the labyrinth. This is therefore known as chemical labyrinthectomy. Okay, nowadays we have a equipment that is known as Silverstein Microvic microcatheter system. Now, what is this Microvic microcatheter system? This consists of a grommet that is known as microcatheter. Inside it is placed a microvic. Okay, and where is it inserted? The grommet is inserted in the tympanic membrane facing the round window, and the microvic goes from the EAC to the round window. So you can see it is going from the EAC to over here, the round window. Now, what is the use of this microvic microcatheter system? A patient, such as a patient of Meniere's disease, can put some gentamicin drops in the EAC, which will be absorbed by the microvic and transferred to the round window and thus into the inner ear. So this system, this is a drug delivery device into the inner ear. It can be used for gentamicin, it can be used for steroids and many other drugs that you need to give to the inner ear. Okay, so that's a microvic microcatheter system. It is used for self-delivery of drug through the inner ear. Next, we now also have a therapy in cases of Meniere's disease by a device that is known as Meniere device. Now, this Meniere device gives a intermittent low pressure pulse therapy to the patient. Okay, now what is this? To give this therapy, first thing that is done is a grommet is inserted in the tympanic membrane. Okay, this grommet is facing the round window. Now, suppose a patient is starting to have an attack of Meniere's disease. Right? Nowadays, we know that it is not the sac which is problematic. The main problem is in the duct. The duct gets blocked. Okay, and it's a physiological blockage. So, if a pressure is given to the endolymph, that will push open the duct, and therefore the fluid will go into the endolymphatic sac where it will eventually get absorbed. So this device, when the patient starts having an attack of Meniere's disease, patient will insert the device in the ear and switch it on. And when patient switches the device on, the pulses, the low pressure pulses, they go intermittently and reach the tympanic membrane. Okay, in the tympanic membrane we have the grommet, and through the grommet they go into the middle ear, and from there they go and reach the inner ear. They move the fluid. This fluid movement pushes the endolymph through the duct into the sac where it is absorbed. Okay, let's look over here in this video. We can see that the cochlea has three parts, and the Reissner membrane or the vestibular membrane is bulging up because of increased quantity of endolymph. Okay, so we have a endolymphatic hydrops. Now, to treat this, we give a Meniere therapy, and in this Meniere therapy, intermittent low pressure pulses are given. These intermittent low pressure pulses from the EAC cross into the middle ear through the grommet. As you can see over here, the grommet is facing the round window, and therefore they reach the inner ear. They move the fluid inside the inner ear. Okay, so you can see the pulses going through the grommet and reaching the round window. That moves the fluid, and therefore the Reissner membrane starts coming back to its normal position. Okay, so that is the basis for Meniere device or the Meniere therapy. And this therapy is now a US FDA approved therapy for home treatment by patient of Meniere's disease. So let us come to the next disease, that is superior semicircular canal dehiscence. Now, before we discuss this disease, let's see what we have studied till now. Diseases of external ear and diseases of middle ear. So we have seen that these cause conductive hearing loss. Okay, whereas diseases of inner ear and beyond inner ear, that is the eighth nerve, they cause sensory neural hearing loss. Okay, they can be divided into two types: sensory, that is cochlear, and retrocochlear, that is beyond the cochlea in the neural pathway, so neural hearing loss. Okay, so sensory cochlear or retrocochlear neural hearing loss. So we have two types major, that is conductive hearing loss and sensory neural hearing loss. Now we are going to discuss a disease. This disease is known as superior semicircular canal dehiscence, also known as third window syndrome. Now this is a rare disease that causes conductive hearing loss. Okay, so remember, this is a disease of the inner ear and yet it is causing conductive hearing loss. So what happens in this disease? The superior semicircular canal is dehiscent. The bony covering over this superior semicircular canal is absent. Now, because this bony covering is absent, the patient has conductive hearing loss. Now, why will the patient whose this part, the bony covering, is absent, will have conductive hearing loss? Now, this is because of a phenomena that is known as third window phenomena. You see, we already know in the physiology that the sound strikes the tympanic membrane and the tympanic membrane transfers the sound to the ossicles. The stapes footplate vibrates as a result and transfers this mechanical energy into the inner ear. The perilymph of the scala vestibuli moves and that movement goes instantaneously in the scala tympani. The perilymph moves and moves the wrong window out. This movement is then transferred to the basilar membrane, and from the organ of Corti on the basilar membrane, it is converted into electrical energy and given to the eighth nerve. Okay, now what happens? Suppose there is another window present. Suppose in the semicircular canal there is a third window present. So you see over here, the stapes footplate is going in and it is moving the fluid in the scala vestibuli. This fluid movement is reaching the scala tympani. Let's see, in the superior semicircular canal, we have a third window. So amount of force transferred by the stapes into the perilymph goes up into the superior semicircular canal, and this force is released by the third window into the cranial cavity. So therefore this amount of force is lost and it will not reach into the scala tympani and on the basilar membrane. So there is a loss of the mechanical energy because of this third window. Okay, and therefore patient will have conductive hearing loss. Okay, let's see, in this video we can see that the movement is coming from the stapes, but it is getting lost from this third window on the superior semicircular canal, and therefore it is not going into the cochlea and causing a movement of the perilymph as much as it would have caused if there was no third window. Okay, how will a patient of superior semicircular canal dehiscence present? This patient presents with vertigo. Okay, patient can also have oscillopsia. That means he will feel everything is little shaky around him. He will not see the stationary objects as stationary, so they will be little out of focus as they will be shaky. Patient may also have autophony, where his own voice resonates in the ear. Patient can have a phenomena of Tullius phenomena, where a loud noise provokes vertigo. Okay, why the patient will have Tullius phenomena? The reason is that any movement of the stapes footplate, even by loud noise, will cause excessive movement of the inner ear fluids, because instead of two windows, now there are three windows, so it is easy to move the fluids of the inner ear. A part of that movement also goes to the vestibular labyrinth, and patient will have vertigo whenever there is a loud sound. Okay, patient also has a complaint of fullness or pressure in the ears. On Pureton audiometry, we will find that this patient has a conductive hearing loss. Alright, so there is a wide AB gap, there is conductive hearing loss. Now, at the same time, remember the patient bone conduction thresholds, they are normal or they may even be supranormal. Okay, so they may be in the negative range till -5 or -10. So, patient has conductive hearing loss. There is a AB gap, so you can see that the air conduction curve has gone down. The bone conduction curve is normal or may even be supranormal. Okay, now why the bone conduction curve is supranormal? The bone conduction curve is supranormal because the sound which is going through the bone directly reaching into the inner ear, now moving the inner ear fluid has become easy because of presence of third window. Okay, so therefore the bone conduction threshold increases, whereas the air conduction curve goes down because there is a loss of mechanical energy which is reaching from the stapes foot plate. This is also the reason for patient experiencing autophony. Okay, now how do we confirm this disease? We confirm it with the help of high resolution CT scan of the temporal bones that can show us the disease, the dehiscence of the superior semicircular canal. Okay, the treatment for this is we have to repair the superior semicircular canal dehiscence that is generally done through the middle cranial fossa approach. So an incision is given and a middle cranial fossa craniotomy is done. As you can see over here, the brain is lifted up with the help of a retractor and you reach this place of dehiscence, and you can see over here that's the place of dehiscence, and this is then plugged in so as to stop the third window syndrome. Okay, so that is how a superior semicircular canal dehiscence is treated.